Good afternoon, everybody. Good afternoon, anybody that is watching us on YouTube. Welcome to the Health and Wellbeing Board for the 28th of November. My name is Councillor Jane Palmer and I will be chairing the meeting. Could I ask that if anybody has a mobile phone, they have it switched to silent, please? We're not expecting a fire alarm or a fire drill, but if there is a ringing alarm, please follow the officers via the exit. Can I remind everybody to use their microphones when speaking so that we can be heard by the numerous members of public watching us? Thank you very much, everyone. And so we will begin by agenda item 1, apologies for absence.
Chair, the apologies for absence that we've had are from Patricia Wright, and Tina's here as her substitute, and we've had apologies from Lynn Hill, and Lisa is here as her substitute.
Thank you very much. Agenda item 2, declarations of interest. Are there any? Lovely, that's a silence, so I'll take that as a no. Then we move on to approve the minutes of the meeting which was held on the 12th of September. They are pages 1 to 4 on your agenda items. If you want, I'm sure you've all read them, so if anybody wants to draw anything to my attention, either that is right or wrong, please indicate in the usual way. I'll take that as agreed, please. We will now go into the main part of the meeting, which is agenda item 5, which is the Hillingdon Joint and Health Wellbeing Strategy 2022 to 25. This is pages 5 to 14 on your agenda. Who's going to lead us through that one, please? Lovely. Thank you, Sonny.
Once again, thank you, Chair. Firstly, we would like to thank colleagues from across the HHCP who have helped us put together the full review report. The purpose of the review is to inform the Health and Wellbeing Board of the progress achieved by Hillingdon Health and Care Organisations in Year 1, which is 2022 to 23, of the delivery of the Health and Wellbeing Board strategy. The paper sets out the process we undertook and identifies progress against strategy priorities, those where we have achieved progress, and those priorities that, due to limited information, we could not determine progress, outcomes, and impact. We also evaluated how we can more effectively measure what is being achieved in preparation for completing an evaluation of Year 2, and have made recommendations that aim to improve this process and help achieve greater progress in Years 2 and 3 of the strategy delivery. So, in terms of process, my colleague Becky Manville and myself, as part of the Public Health team, were asked to review Year 1 of the Health and Wellbeing Board strategy, and started by developing a framework that sets out the Health and Wellbeing Board strategy priorities and the progress reported in Year 1. The Health and Wellbeing Board strategy has 6 thematic priorities to, number 1, support children, young people and their families to have the best start and to live healthier lives. Number 2, tackle unfair and avoidable inequalities in health and in access to and experience of services. Number 3, help people to prevent the onset of long-term health conditions such as dementia and heart disease. Number 4, support people to live well, independently and for longer in older age and through to the end of life. Number 5, improve mental health services through prevention and self-management. And number 6, improve the way we work within and across organisations to offer better health and social care. These 6 priorities are supported by enabling 6 work streams through which thematic priorities will be delivered. Neighbourhood-based proactive care, urgent and emergency care, end-of-life care, planned care, care and support for children and young people, care and support for people with mental health challenges, including addiction and/or learning disability and/or autism. The strategy states the intention that each priority is to be delivered through a HHCP transformation board, and colleagues from across HHCP were asked to provide the following information. Identify the responsible officer for each work stream and other officers that could provide information of the individual projects identified in the Health and Wellbeing Board strategy. Identify the lead group responsible for delivery to determine which forum has overseen the progression of each of the work streams, to provide relevant baseline data and information to set out the starting point of the strategy delivery, any agreed ambitions, i.e. targets, with direct and indirect performance measures. Reporting processes through the lead group that oversees progress and performance, the achieved activity and outcomes for 22-23, and how a partnership approach had contributed to this achievement. And finally, plans for the 23-24 that are progressing. We found the review process to be more challenging than we expected. We identified a lack of clarity about which transformation board had taken responsibility and whether they were aware of the requirements of the strategy. There were also difficulty identifying the lead officers responsible for delivery who could provide the information on the progress achieved for each area. There is a lot of activity aligned to the strategy, and it is clear from the work in progress that the priorities in the strategy are the correct ones. However, the planned priorities of the strategy and what is needed to deliver them needs to be better understood and socialized. We are therefore grateful that despite this, officers across HHCP helped us capture information and data on the thematic priority, and when needed were able to signpost us to more appropriate officers who could contribute and help determine progress and gaps to qualify a 22-23 update. Our findings. We identified 10 areas where progress was made in 22-23. Despite the strategy not having identified a starting baseline measure for which progress can be measured, we retrospectively added the baseline based on previous year's reported data. One of the other areas that we found needed more robust processes was evaluation, and whilst there is progress, measuring this quantifiable needs to be further developed. Examples of where progress has been made. Tackling falls and falls prevention amongst older residents in Hillingdon, and we're looking at population over 65 group. We have produced a falls directory of services, developed a falls decision support tool, also known as DST, produced a resource pack for falls prevention and management in care homes, developed a falls prevention training program for care home and extra care housing staff, more effective evaluation through data that can demonstrate a reduction of falls across this time period as a quantifiable way to measure outcome and impact. Also, we have in the preventative care hypertension workstream, there has been the development of hypertension webinars in various languages hosted on the Confederation website, promotion of the community pharmacies offering free blood pressure checks, event calendar highlighting opportunities for conducting blood pressure checks, and wider support available for patients at risk of hypertension. We've developed pathways to send community blood pressure check results to general practices directly to escalate high-risk patients. Again, evaluation methodology that demonstrated the impact is being developed. In support of dementia, supporting residents with dementia and their carers, we have a Borough-awarded dementia-friendly community status with 10 venues accredited under the Dementia-Friendly Venue Charter. Residents living with dementia and their carers can now access 13 different activities weekly, offering 230 free spaces. There is considerable good work being progressed in this area, and similarly, the recurrent theme is to measure the impact that it is having. Conversely, there are areas where progress has not been demonstrated, either due to limited or no information provided, or the information did not demonstrate what was achieved. This finding is open to challenge, and we would be happy to review these areas further. We identified a lack of progress in the 22-23 in, for example, reducing the prevalence of overweight, including obesity, children in Year 6 in Hillingdon, which continues to remain above the England and London averages. In addition, the proportion of physically active children and young people is below the national average. The CNWL school nursing team continues to deliver My Choice, a healthy weight intervention program across the borough. However, capacity is limited and take-up is low. There is awareness of this issue, and it is being addressed as part of the 0 to 19 service review working with PH. Okay, let's just move on. Our findings. Oops. Let's just come to that over. Yeah, okay, from here. For improving the way we work within and across organisations to offer better health and social care, in relation to workforce development, we were not able to establish whether there was HHCP Integrated Community Workforce Plan and the monitoring of vacancy and retention levels amongst ASC providers and what intervention to provide support when there are issues are in place. This could mean we were directed to the wrong persons. Again, we would be happy to update the review with subsequent information that could address any of these areas. Given the challenges we identified, we considered how we could improve the review process in advance of a Year 2 review. I've stated many of the challenges to completing the review and evaluating all areas from the initial strategy, not setting baseline measures or indicating progress ambitions and targets for each year and the full 3 years, either using direct or proxy data measures. There was limited awareness of the strategy and therefore was in some areas not fully embedded in work streams. Plus, we could not always find the right officer to help us review and evaluate. As part of our recommendations, we would like the board's agreement to establish a process that will help the board have oversight of progress. We will agree baseline information and targets with identified lead officers and the direct and proxy measures through which we will evaluate progress. By doing this, we can socialise the requirements of the Health and Wellbeing Board strategy across HHCP transformation boards and subgroups and confirm responsibilities. This review created a lot of additional work for all involved, which should have been core business. A more efficient and effective process using an up-to-date contact list of SROs, lead officers and forums will improve the data gathering process and allow greater time for analysis and clarification of information submissions. Our recommendation is that we ask the board considers the recommendations made, including a revised evaluation process, anticipating the need to evaluate Year 2, 23-24, of the Health and Wellbeing Board strategy led by the LBH Public Health team. So, I just end there, but I ask Kelly if there's any further information that you would like to add. Thank you.
Please do.
So just in summary, is that the process actually has been really challenging. After having read Gary's report, I think what we found is that the strategy, the BCF, the ICB metrics and the performance report, there is significant crossover. But if you drill down into the strategy and the way the strategy is presented, because it doesn't follow a linear process and it has no initial baseline, the ability to actually measure progress for some areas which are not quite so obvious, which don't have those direct sort of either direct measures or proxy measures, is actually really difficult to quantify. So one, just in terms of that recommendation, if we're going to review Year 2, I think there needs to be sort of quite significant sort of link up so that we're not asking people to do something that they think is over and above their job, but there is a little bit of socialisation that's required to make sure that these areas in the strategy are fully embedded into transformation boards and they're being overseen on a regular basis. And that's not denigrating the work that anyone has actually done, but actually it'll just make it easier to really sort of provide some assurance to the board that the progress that we are expecting is actually being delivered. And that is definitely not to say that it's not being delivered. We just didn't have a starting point, and we didn't have milestone measures to be able to quantify it. And part of a strategy process is to be able to have all of that in place right from the outset, and that wasn't available. So it's rectifiable, and certainly the priorities are the right ones. It just needs a little bit, in my opinion, I'm offering sort of the opportunity to make that process a bit slicker, linking up with Gary, linking up with the transformation boards, to just put back in place those measures that we agree as part of the strategy, in order that that focus is maintained and delivered.
Thank you, Kelly. Before I ask the board to consider the recommendations, would anybody like to speak? Keith.
Thank you, Sonia, and thank you, Kelly. Good to see you both again in this meeting. First of all, Sonia, apologies. I don't think you were able to access the right people and therefore the information in the timeline to fully complete the evaluation. I think we need to collectively own that as a group. So, just to reassure the board and to reassure, obviously, public watching at home, we have clear work streams, SROs and operational leads for each of the 6 transformation and work streams. They are reported at the HHCP delivery board, and they're reported here every quarterly basis through an IPR and through Gary's report. They are, in fact, the next agenda item is highlighted, a report on the metrics of the health and wellbeing strategy. What I would agree, Kelly, I would agree that what we need to do, Kelly, quite happy, so need to have that conversation offline and make sure we connect with the right, because I think it's important we report the right things, and the work, the phenomenal amount of work that's been done on this is represented and through this group. But I do agree, we just need to make sure we reinforce the existing governance and the reporting and milestones. I'd hate us to think we set up another set of governance and another set of reporting, because I think we'd all implode under the weight of that. Of that. But I think you're right, Kelly. I think what we just need to do is make sure that we are benchmarking and baselining the strategy so that we can monitor progress against it. But very happy from the outside of the meeting to work with you on that. And I think you have dealt quite a difficult hand in quite a short time scale here. So thank you for the work that you've done. And I think we'll collectively work with you to make sure, perhaps, if I may, Jane, to you, just to bring back an updated baseline, maybe to the next meeting, just so we can make sure and give assurance to the, to the board that there's clarity on what we're trying to do. We can always improve it, but that there is clarity on what we're trying to do.
Thank you, Keith. Does anybody else want to make any comments? Tony?
Thank you. I suppose just to build a little on Keith's points, really. I think that for the purposes of the board, and I think people watching, hopefully in their thousands, that actually there's a whole array of work that is operationally going on sort of day in, day out, against which there's a bit of a chicken and egg point here, because there was lots of this work sort of going on. This was a structure sort of put around, if you like, to capture and encapsulate all the work that's happening operationally. And I think there's probably things in here that probably are better outside of the board, that sort of prior to sort of coming here, because we've got 2 different bits of engineering going on, I think. We just need to bring them together. So I just again wanted to offer the reassurance from, as far as I am aware, and I'm sure Sandra and others who lead operational services in the room would say the same thing, that the operational delivery against the range of things in here is sort of well underway, in some places very mature, and delivering. But equally, point to Sonny and Kelly absolutely right, is that we have to be able to evidence that. And the evidence comes from having a baseline on which you show progress. But I just wanted to offer the broader reassurance.
Thank you. Councillor O'Brien.
Thank you very much, Chairperson. I think that, notwithstanding what we have to agree with recommendations today, I just want to probably highlight my disappointment and sadness really that we have not been able to progress in the area of child obesity. Just looking at the focus area that we still haven't, I think I've probably raised this at least 4 times within this forum, if not outside of this forum. It's really sad that, that we're not able to do anything more. Children don't become obese in year 6, they're obese in year 5, 4, 3, 2 and 1. They were probably obese in reception when they were first weighed. And again, I just want it to go on record that it's really disappointing that my choice is not delivering what it needs to do. Capacity is limited, take-up is low, and many people don't even manage, or young families or the children themselves don't even manage to get through to the end of the course, which just really shows me how engaged they must be during the course of it. Thank you, that's my only comment for today.
Thank you. I would echo that Councillor O'Brien's comments. I mean, having attended a opening of a tennis court in Hillingdon and seen the amount of children that couldn't wait to get onto the court and hit a ball, I'm quite surprised that we can't encourage them to do something in order to make healthy weight more attractive. Professor Goodman.
So this is going back a bit to what Tony was saying and Kelly and Sunny, that I just wondered, there's a lot of work been going on that's identifying processes. It's not clear what the outcomes are, and I think what may be helpful is whether we have milestones in the paper to say, right, from this point here in 6 months I want to be here, I want to be there in a year's time, whatever. So then we can actually judge whether we're on target to hit our defined target, our outcomes. There's a lot of mention of the word outcomes, but there's very little about the definition of what we mean by that outcome. And I suspect we mean different things. If you ask different people what an outcome is, they won't come up with the same thing. I think we need to be a bit clearer about that, and that may make it easier, A, for the baselining, and B, for the monitoring of the process and the reporting back, and knowing where we are with that process to actually get where we want to get to.
I think that's a relevant point. Kelly, do you want to address that at all?
There's, to be honest, I think that there was an interchangeable view of outputs, outcomes and impact, and actually we do need to read in the actual document strategy itself. We refer to we refer to increasing access, improved outcomes, and people's experience, but we don't really say what they actually are. So I think, on reflection, if we set up some clear measures, direct and indirect, whether they're proxy, because clearly a strategy needs to have access to relevant and accessible measures. We just need to be really clear about what those measures are measuring, and it's not just footfall. It's about what has actually been achieved as part of the processes that are being delivered. So, in terms of that sort of revision that we're recommending, we can much more clearly define that, and in the same way, Ian, is just make sure that we have milestone measures year on year to be able to demonstrate that we're achieving the improvement at the pace that we had anticipated. So, if that's a recommendation of the board, I'm happy to take that way. But there is Gary's paper, which clearly is, as Keith has said, is clearly showing a sort of a tandem process going on.
Vanessa?
Yes, thank you. I just wanted to address Councillor Susan O'Brien's question around the school nurse programme, the My Choices, and I know that we have been sat here before saying exactly the same thing, so it is really disappointing and disheartening to see that there is still very limited take-up. What I will say is that we're looking at the two things, so engagement, so why we don't have that engagement, we're really trying to unpick that with young people themselves. And the second thing is we are looking at a transformation. We have a transformation programme that we are delivering around family hubs and our 0 to 19 services to think about how we actually really focus on obesity in children. So those are the two things that I would say about your question. And I do hope that we're sat here in the distant future, making sure that we've got a better measure there. The second thing I just wanted to address is I am one of the SROs as part of the HHCP, so the SRO for mental health, learning disabilities and autism, and I'm really happy to engage with yourself in terms of making sure that you've got the information you need, and apologies if you felt you didn't have that. Because as you'll see in the paper that will be coming next on the agenda, there is a significant amount of progress in that transformation board that I chair. Thank you.
Thank you, Vanessa. I would say that thank you for what you said there, and I would hope that, using the word hope, that when we begin to talk about children's weight, hope doesn't come into it. I would like to see next time we meet that there is evidence that we have actually moved on in that plan. Does anybody else want to speak on this particular subject? If not, I just want to say that there are a couple of really good pieces of work in here that I would personally like to highlight, and that is the Falls Directory. Absolutely excellent piece of work that is envied across North West London with my colleagues, and I'm very proud to sit on an ICB that this is being showcased at. So congratulations to everyone that's involved with that. And our dementia work as well is very well thought of across London, and our residents are, although experiencing a very difficult illness, are fortunate that they are very well cared for in this borough with our dementia services. So I just wanted to highlight that. Which brings me on to the recommendations of the board. So I would be asking the board to consider the recommendations. Are we happy with them? To me, it looks like we're going in the right direction. This is a very good start. And to agree to a revised evaluation process. We've heard of the difficulties that this has brought together. Are we in agreement that we can agree with these recommendations and move forward?
Agreed.
Keith.
Just with one amendment, because it's 5.3 on this. We've got developing and implementing a governance process with a formal rollout to ensure. I wonder, Chair, whether we can consider just it is about reinforcing existing governance processes, not creating more governance processes, and tightening the reporting and the milestoning, because it's just basically building on what we've got rather than creating more governance and more processes. Because I think, I have to say, it goes back to Tony's point, our operational staff will just implode under more governance processes.
Very sound comments from my co-chair. Nikki, did you get the essence of that amendment? Are we happy with what's been said there?
Agreed.
In which case we can agree that and move forward onto the next agenda item. Thanks very much. Which, if I've got my numbers correctly, should be agenda item 6, which is the Integrated Health and Care Performance Report. We've got it in front of us, page 15. Gary, are you going to talk to that?
I am, Chairman, thank you. I just wanted to start off, Chairman, by making the board aware of some recent information that I've had through the NHS England Better Care Support team, which impacts on some of the activity that we're going to be required, reporting activity that we're going to be required to undertake in quarter 4 of this year. So, firstly, the board actually has the quarter 2 performance template as part of the report. We are going to, funnily enough, be required to submit a quarter 3 template, which will be looking at activity spend and updating progress on metrics. There will also be a 24-25 addendum, which will basically be looking at what our plan is going to be, or a refresh of our plan for 24-25. That will also include an update on the intermediate care demand and capacity template. And on that, discussion with partners is leading to the conclusion that it would actually be helpful for us to accept an offer of support from the Better Care support team with undertaking that refresh. In terms of timescale, the expectation is that we are due to receive guidance on the 24-25 addendum either in December or January, and that both the addendum and the quarter 3 reporting template will probably have to be submitted by the middle of February. On that basis, I'm actually going to ask the board's permission to give delegated authority to the corporate director for adult social care and health in consultation with yourself, Chair, and with the co-chair, as well as the chairman of Health Watch Hillingdon, to sign off the template. What I would say is that if there is an opportunity for us to bring those to the board for final sign-off, if the submission deadline, the national submission deadline, allows that, then that would be the preferred option. But as I say, I would be asking the board's permission for those delegated arrangements.
Does anyone have a problem with that before we move on to something else on this agenda? In which case, Gary, that is approved by the board. Thank you.
And Chairman, I have provided some wording for Nikki for the minutes.
I knew you would have done.
I'm not going to go into a great deal on the contents of what is a very long and detailed report. The board will probably be pleased to know. I just want to highlight some points on the quarter 2 template. In terms of the metrics, as you can see, we're slightly off kilter on the discharge to usual place of residence. We are on track with 2 of the other metrics, and on the residential admissions, there is a considerable movement from the target, and the reasons for that are explained, but essentially we are looking at a considerable increased needs coming through, some of which we would attribute to the legacy of COVID. And I do want to assure the board that there is a rigorous process in place that ensures that discharge to admission to a care home as a long-term residence does actually follow a rigorous process to ensure that is the most appropriate setting to meet a person's needs. Moving on to the demand and capacity template, I think the key points from this is that on pathway 1 we have an underutilisation of the services available, and that is being addressed, and we are seeing progress in an increase in the utilisation. On the pathway 3, which is the discharge to care homes, the issue there is around capacity, and we are seeking to address that, and there are various discussions that are actually taking place. However, and suffice to say that is not necessarily an easy nut to crack because of the actual capacity within the local care market. I just wondered whether the board had any comments that they wanted to make on this aspect of the report.
Does anybody? Keith?
I think it's just helpful. Thank you, Gary, for that. It's just a segue to the previous agenda item, I guess, is and maybe Eddie and colleagues may have some more comments to add, but for example on work stream 1, I would just draw attention to the work that's taking place on the development of integrated neighbourhoods in terms of proactive care, and there's a huge amount of work has taken place there in terms of taking that forward quite significantly. The work around same-day urgent primary care hubs, critical component of neighbourhood development, but also of the hospital redevelopment plan and urgent and emergency care. And then, as Gary has, the implementation recently of a new end-of-life model that went live last week. That's the first time we've had an integrated end-of-life service in Hillingdon. And then obviously the work you just referred to, Gary, in terms of length of stay at the hospital. Gina and I've got the scars on this one. That is a significant piece of work that we're all engaged in at the moment to help reduce inappropriate lengths of stay at the Hillingdon Hospital. Again, as part of a longer-term plan to make sure that when we have our new hospital in it's right-sized, basically. So I just want to draw those things to people's attention. They are major pieces of work, of which we have the SROs around the table for each of those. So I just want to make sure the board is cited on that.
Just to add, Chairman, that some of the other key areas that I was actually going to say around some of the changes to the to neighbourhood teams, the geographical changes, so they're moving from 6 to 3 to actually better or help better fit with other support services. And in terms of the range of metrics, the board can see that it's a bit of a mixed bag, and some areas we're doing particularly well, particularly on flu and COVID vaccinations in comparison with the rest of North West London. Thank you, Chairman.
Sandra?
I just wanted to add to some of the things that Keith has said. I think it's really important that we all, ourselves included, grasp the fact that we're not sharing as much about what we're doing as we could and should, so that we can demonstrate to the board, but also, I mean, it helps motivate people to know that we're making a difference. And I think we are making a difference. We're just not clearly getting this into the right place at the right time in terms of reporting. So I think that that's for all of us here to take away, because, as Vanessa said, she's proactively working as an SRO, but we're not capturing that information. So I think it's important we just remember that today and look for next time's report to be more fully inclusive.
Thank you. I mean, within the report there are, it is highlighted some really, really excellent pieces of work, which possibly people aren't aware of, and I do think it is important that we recognise that. Gary, I want to personally thank you for the work that you've put in over this whole BCF, and everything that you do has not been easy this year. And once again, I've been able to sit on the board at North West London and sit there with a slight smug face off camera, because we in Hillingdon are doing very, very well. We have excellent partnership working around the table. It's evident from the attendance of this meeting how seriously this borough takes working, joined up working with health and social care. But your job this year has been even more difficult than it usually is, and you've done it with your normal good grace and cheerful smile, and I personally want to thank you for that. It's been really, really hard, and we're in a very good place, and we should all really be proud, but you deserve a special Councillor Palmer smile across the table.
Won't get us head up.
We get one.
No, Councillor O'Brien. Seldom will you get one. Do we have anything to say other than, if not, then we hopefully can listen to the update, be very proud of what we do. We've already agreed the delegation of the extra template, so we are seeking approval for the template, and I think we've agreed that. So unless Nikki advises me otherwise, I think we can move on. Can we? Thank you. So we'll move on to agenda item 7, whatever that is. I can't get to it quick enough. Of course. Sorry, Tony.
I was taken by your slight smugness. I'd be very smug if I were you in that situation. No, it was just really, it's quite interesting having heard a number of the things that we've just talked about, because for those of us that have been around the table for a little while, I suppose we know it, and we're aware of where things have come from, all the iterations of things of sort of getting to where we've arrived. So I'm just going to put it out there as something maybe at some point early next calendar year, that we probably ought to have a bit of a stock take in terms of just even the operating model that Keith talked about, into the models of integrated care and those the neighbourhood models and all of that. Actually, to those of us that know that, we know what the words mean, and we know what it is. But we probably ought to find some time to have a session with sort of key people to pull that together, in order that we've got something almost like as a compendium of the both achievement and ambition, because it ties in very well, particularly with all of the things that we know have to be in place for the new hospital to be able to sort of operate based on its sort of current design. So it's just to put out there that I think one or two or three of us ought to, outside of this, think about a session which probably would be a board session, but for something where we sort of collate and pull together the sort of various things that we've been doing, because otherwise I think it is right. As I say, I can speak with confidence and rattle on about it because I know about it, but that's because I've been around the tables a lot. But for residents of the borough and for others, it's a load of terminology and it looks like restructuring and rearranging of things rather than actual impacts and changes to the way in which they're going to be able to consume healthcare services in the borough, which I think is important that we spend the time doing. So, yeah, I'm happy to be a part of that as well.
So can we minute that you will take that forward then, Tony?
I'm not sure I said that.
I think there's enough witnesses, enough laughter around the table to convince me that you actually did say it. Thank you. So I think what we'll minute there is, Nikki, that Tony is going to organise that little vision that he's just had off the top of his head.
I'll delegate it appropriately.
Fair enough. As is your will. I care not how it gets done, but I think it should get done. Lovely. Brilliant. Can we move on to agenda item 7, please, then, from harm to hope, which is the combating drug and alcohol misuse. And welcome to Gary, and I think you're going to talk us through this.
Thank you, Chair. My name's Gary Hutchings. I'm a public health strategist for the public health team in Hillingdon. Just wanted to say thanks for giving me the opportunity to give an update on the implementation of the From Harm to Hope strategy for Hillingdon. The 10-year strategy that came out in December 2021, based on the Dame Carol Black review, which was sparked by the fact that drug and alcohol-related deaths had gone up by 80%, I think, since 2012. So this new strategy was put forward with 3 years of grant funding, and obviously the paper's been circulated, but I'll just give you the headlines and hopefully do it succinctly and hopefully get Councillor Palmer's smile at the end, if I've earned one. From Harm to Hope, a drug strategy, supplementary national funding was 85.7 million across the country. It's overseen by the Office of Health Improvements and Disparities, OHID. The supplementary funding is called the Supplementary Substance Misuse Treatment and Recovery Grant. I won't say that again. SSMTRG, it's a bit of a mouthful, and OHID that I'll refer to, that would sort of overseeing this piece of work and the metrics. There's a real emphasis on this, we've spoken about collaboration, I think, already, and genuine collaboration and collective accountability for the metrics, rather than just the sort of addictions field itself with the rest of the system, because that's essential. There were certain criteria that we had to meet as a borough. One being the 2023 needs assessment, strategic needs assessment that we completed, which was identified. It's great knowing the people that do access the services and have access to services. This tells us a little bit more about who doesn't and how we can reach those people. So with that, it's been really helpful, because the adult service is currently out to tender, so that's enabled us to really put the new service specification together to try and really target those neighbourhoods and the people in them. So in terms of, we're in year 2 of the SSMTRG now, so we're around about £657,000, well, exactly £657,000. And there's also an overlap in terms of the collaboration with other supplementary grants, like the Rough Sleepers Drug and Alcohol Treatment Grant as well, which is £598,000 for this year. But unfortunately, that does end in March, which can put, we're contingency planning now to see what we're going to do, because that fund has been used really well in Hillingdon, and that's coming from a person who's previously worked outside and looking outside in. There's been some fantastic work, which I'll move on to. And this supplementary grant is on top of the 3 million, circa 3 million per year that we have for the current contract. So in terms of the Rough Sleepers Drug and Alcohol Treatment Grant, that's managed by the housing team, and that's provided community homeless outreach teams. That's been really successful, and there's some fantastic clinical interventions there. Psychology support team, and an additional inpatient detox budget for people that are experiencing homelessness or have got a history of homelessness. And in terms of the SSMTRG funding, it's managed by the public health team here. That's funded a hospital-based clinical team, which links together the hospital and the community service, criminal justice intervention workers, so in the community and in the prisons as well. Co-occurring conditions nurse, so with those with substance issues and mental health issues, it's co-located within the mental health service. That's now in place. And link workers between the young people and the adult service, because a lot of young people can fall through the gaps without that support going between one service and the other, because they look very different. So that's how the fund has been used so far. In terms of the governance of the project, terms of reference were agreed at the Safer Hillingdon Partnership this year, and the SRO and the operational lead roles agreed. And there's other things, also recommendations that each area were given on what groups to implement. So we've got the Combating Drugs and Alcohol Partnership Board, which the next meeting is tomorrow, in fact. The inaugural meeting was in August this year. Brilliant representation in that for Hillingdon, which has been really positive so far. And as in addition to that, there's a joint treatment support group that's due to start in 2 weeks' time as well, and a drug and alcohol mortality review panel also that's going to be starting in January, so we can really take the learning from those serious incidents. In terms of the metrics of the outcomes for this strategy, as I said, we're overseen by OHID, but the aims are to reduce drug use, reduce drug-related crime, reduce drug-related deaths and harm, reduce drug supply, increase engagement in outcomes. And Hillingdon is doing particularly well compared to other London boroughs in all of those fields, which I'll get on to. In terms of the other performance, one of the aims is to increase numbers in treatment. And at the moment, there's 1,579 Hillingdon residents accessing treatment and support. That's just structured treatment, not unstructured treatment. So that's well above the baseline of 1,205 in 2022. So that's a really good outcome. In terms of continuity of care, as it says in the paper, that's people that have got drug and alcohol treatment need, that are in prison, that are seen within the community in structured treatment within 2 weeks. We're on 35% for that, which is above the London average of 27%, and again we're in the top 5 for that, and that's even without the prison in-reach worker that's only recently been taken on. So with the new service specification, we're also expecting that to improve again. Successful completion, so those people that meet their treatment goals and leave treatment or are discharged, and we're on 23%, which again is really good performance across all substances. This information is from the National Drug Treatment and Monitoring System. And the new presentations into treatment, it's all very well, as I said before, in terms of knowing the people that have accessed treatment before, left and come back again, but for Hillingdon there's 645 new presentations, which again is in the top 5 for the London boroughs. So that shows we're getting out and about and really sort of extending the footprint of the service, which will happen even more with the new service specification. In terms of how useful the Controlling Drugs and Alcohol Partnership can be and how effective we can be, there's a case study here that was taken from the Hillingdon Suspected Suicide Learning Panel of a male, a young adult with a history of substance misuse, gang affiliation, a history of mental health issues, series of treatment episodes, didn't particularly engage very well, alcohol and cannabis issues, really sporadic engagement with services, some psychosocial issues as well in terms of the gentleman was unemployed, had housing issues, had been given an eviction notice, and had issues with benefits also. Was also awaiting sentencing following a recent conviction, which is a very stressful time for people, and we've seen a correlation between that and other serious incidents as well for people. So with that, what we're working to put in place on the back of that is the one-stop clinical and support service, so people come to see people in an area where they feel comfortable, but for addictions, but also get support with their mental health, benefits, housing, and anything else that comes along with Citizens Advice Bureau, NHS health checks, all those things that we can put into one place. More of a making every contact count approach, softer, less clinical interventions as well, things like in art groups, music, other things like that, those sort of focuses as well to build time. The co-occurring conditions nurse is in place, so that would have really helped in this particular case to better standards of care. And also we're looking at stepping up support for people that have become involved in the criminal justice system as well, and step up the support around that. We've lived experience of people that have been through the same thing as well. In terms of the effect on residents, this has achieved improved outcomes and will continue to. We've invested in prevention, early intervention, and improved treatment outcomes. And addiction, there's sort of a relatively famous saying in the field that it's non-discriminatory. It affects everybody, all families, all communities, all echelons of society from different parts, and the ripples go out a long way. So this does help across the communities, and also can be in a positive way. There's an element of workforce development in the service specification as well, offering opportunities to people that come through treatment that are very skilled and very knowledgeable and experts in lived experience. And obviously synergies with other strategies like the Hillingdon Stronger Communities, Joint Health and Wellbeing Strategy, Homelessness and Rough Sleeping, and Hillingdon Resident Family Strategy as well. That was a lot of information. Thank you for listening. If anyone's got any questions about anything, I'd be happy to.
Kelly?
Just picking up on Keith's point about the bureaucracy and the governance, this was prescribed. So the governance structure and the framework for reporting is a must-do for all areas. So yeah, it's not about us putting in place those arrangements. We had to. It was mandated as part of the funding. Yeah. So I was just kind of aware when you kind of mentioned that, and just a couple of things just to add in. Is that this additional funding has been huge, and next year is year 3, which is just shy of £1.1 million, and that has created such an ability to be able to ramp up where we used to be when there was significantly more investment in drug and alcohol services. You know, I'm talking of sort of 15, 20 years ago, and just to point out that CNWL as our main provider is, you know, for both of that, you've got two services, I know that, both of those are in the top 3 in London for all of these areas, and for us as commissioners, it means that we don't have a great deal to do when we've got a provider who's actually been really responsive to this. So I just want to say really thank you, because that takes us off very difficult steps with OHID, because so many of the London boroughs are on massive improvement plans. And just to say, in terms of the case study on B, so I chaired that panel, and I think when you start looking at those individual cases, and B is not alone. There are many, many risk factors that we see as part of that suicide panel, where a combination of those factors, we did choose one which is very, very complicated, but actually the work that's being funded now through the sort of the number of posts, the new way of working, has really put in place those risk mitigation measures. So what we're now seeing is the opportunities to sort of be more preventative, intervening early, and getting people into those services, particularly those people that are displaying that risk factors, on top of the kind of suicide prevention work that we're doing. So, yeah, massive boost. Oh, and last thing, is that this is 3-year funding, but OHID are anticipating that the additional funding will come next year. But we're just mindful that we don't know how much that funding is going to be. But it is highly probable, likely, whatever is the most positive, that more money will come, thankfully.
Professor Goodman.
So this really is an echo of my previous question. Do we have a baseline before we started? And also be very, very useful, and I'm very interested to actually know how you measure reduced drug use and what those figures are, and sort of what the recidivist sort of figures are, and also with the rest of those outcomes. Be useful to actually have some data behind that. We can see that in the report.
Yes. So I'll answer that for you, Ian. Essentially, it all comes through a national data system called NDTMS. It's the national data system for the drug and alcohol services. It is essentially it is a compilation of all of the data that's required in terms of continuity of care, what's been achieved, and it shows sort of month on month or quarterly, quarter on quarter?
It's month on month.
It's month on month progression, so you can absolutely monitor it in real time. So we know the baseline from the start, and I have to say that one of the challenges, you get lots of money, but one of the challenges is the reporting system, and I don't mind saying that because so many of us have complained, is an absolute nightmare. So actually we're held to account for all the things that we've said before about how do we improve, how do we set baselines, what's our progress report. That is really, really strictly monitored, essentially has held us to account.
Could we have some figures in the next report?
Yeah, sure. We can circulate them after the meeting, actually. Is that right?
Okay. Tony?
First of all, thanks, Gary. Really well presented. And just a point, I don't entirely know my question, but I'm going to ramble on anyway, because I think it's the kind of read across, probably more for Vanessa really. It's the read across to, I'm thinking sort of parochially, but obviously borough-wide impact, about our children's services and housing services, and just thinking about, so obviously the issues that Julie will be very familiar with in terms of the presentations in relation that have an alcohol-related feature to them, but also in terms of tenancy breakdowns and homelessness. And I just wonder whether there was a way of tying up more towards those triggers that are seen through those other channels. I say it's likely to be closer already in the children's one, but probably less so in the housing one, because obviously we get presentations of people, and quite often when it's about tenancy failure or tenancy breakdown or something, it's often about something else, obviously. And I just wonder, I don't know the numbers off the top of my head, but I'm just interested to know if there are an our housing service to help you with those numbers, to know what what those numbers are, and whether there is a material point at which we should actually perhaps focus. Because obviously once then somebody becomes homeless, that has a whole range of other dominoes that start to fall. Thank you.
So I probably can't answer your question quite without having the detail. I guess one of the things we do need to consider is how you've talked about young adults in this piece of work, and how far do we go down in terms of young adults, and maybe we do need to consider our kind of children's pathway in terms of this piece of work. So to Tony's point, so without kind of having the detail, I think it's a really good point, and maybe we do need to consider that kind of younger adult pathway.
Julie?
Thanks, Vanessa. I suppose my mind's more focused on parental use, because we do have pathways and support and commissioned via public health sorted services for our younger people who may be misusing alcohol or drugs. But its impact on parental drug and alcohol misuse, the majority of our children in child protection, it's neglect, but that's often as a result of something, not just neglect in itself. And we had a discussion today, we had performance monitoring board today with Councillor Brian, repeat babies that are removed from parents as a result of drug and alcohol issues that aren't addressed, and they're not addressed in the time scale that the people are involved with children's services, because that will come to an end, and then they have no children, so where do they sit? So those are the things that sort of exercise my mind as I was reading through and thinking about, well, how can we ensure that we capture those?
Vanessa?
Sorry, just to come back, and I guess one of the things that really struck me was the kind of making every contact count. You know, we've got making every contact count here, we've got family hubs that we're really kind of running over here, and actually how do we bring all of that together? It may well come through one of our young adults or children, in that that's how we may become aware that there's a particular issue and not the drug and alcohol service. But it is how, I guess I'm thinking, how do we pull all of those strands and services together, which would be really interesting, and maybe something we do need to pick up outside of here that will support the borough.
Kelly?
So just to advise the board that we are currently out to tender with the drug and alcohol services, and just picking up on the parental support and family dynamics and relationships when they are living with a parent with addictions. That is emphasised significantly more than was previously as part of the model in the new model.
It's good to hear. Any more comments? Okay, so in summing up then, I just want to highlight that in the report it clearly states that Hillingdon and Hounslow are the top performing London boroughs for residents in treatment. I think that needs to be highlighted, and also that with the new prison in reach worker, we're within the top 5 of all London boroughs. So that this is an excellent piece of work. You do get a big smile, because alcohol is not, no one is born an alcoholic, notwithstanding you can be as a child if your parents are, but however it can happen to any one of us, and it's not just the alcohol. It clearly impacts on your housing, your job. You could lose your licence, you could do all sorts of things under drugs and alcohol. So for me it has to be looked at in the whole, and I think this is what we're clearly doing, and I'm sure that when we read the report we all thought very much of person B, and I would ask the board to hold that person in our thoughts going forward today, because out of that we have also managed to understand, sadly, where that person could have been helped, and all we can do going forward is to try to make sure that if anybody is in that situation again, there are things in place that much more support. So it was a sad thing to read, but sadly that is part of the subject matter. So thank you very much, Gary, for bringing that to the meeting. So I think, what do? We're just noting it. Note the recommendations, I think, which we have done, in which case thank you very much, and I'll move on to agenda item 8, which is Stopping the Start, Creating a Smoke-Free Generation and Tackling the Youth Vaping, which I'm going to call an epidemic. Is that you, Sonny? Lovely. Please go ahead.
Thank you.
If I can ask you to speak, because we've got the report, so we...
Top class. Perfect. Thank you, Chair. Tobacco control. As an introduction, the government has introduced a historic new law to protect future generations of young people from the harms of smoking. This is probably the single biggest public health intervention in a generation to stop children from ever being able to buy a cigarette. The new government strategy called Stopping the Start, our new plan to create a smoke-free generation, lays out the route for addressing the harms of tobacco addiction by supporting smokers to quit, preventing addiction to smoking before it starts, and curbing the rise of vaping in children and young people. So this will be achieved basically by creating the first smoke-free generation. Legislate to raise the age of sale 1 year every year from 2027 onwards. So the proposed new legislation will make it an offence for anyone born on or after January 2009 to be sold tobacco products, effectively raising the smoking age by a year each year until it applies to the full population. This is following in the footsteps of New Zealand. This does not criminalise smoking, however, takes a phased approach for anyone legally being sold tobacco. So supporting people to quit smoking, double the funding for local authority stop smoking services through the new Treasury money available from April 2024, increase funding for awareness raising campaigns by 5 million this year and 15 million from next year onwards. This will fund national tobacco marketing campaigns to explain the changes, the benefits of quitting and support available. Very importantly, curbing the rise in youth vaping, reducing the appeal and availability of vapes to children, striking a balance with ensuring vapes are available for adult smokers to help them quit smoking. And of course, strengthening enforcement activity. So new powers to fine road trade retailers on the spot who sell tobacco products or vapes to people underage, action to track down illicit tobacco and vaping products and take further steps to enhance online age verification. The increase in funding will facilitate enforcement on illicit tobacco and e-cigarettes through £30 million from next year to further support agencies such as local trading standards. The health risks of smoking and nicotine. Smoking is highly addictive, with 4 in every 5 smokers starting before the age of 20 and remaining addicted for the rest of their lives. By stopping young people from ever starting to smoke, the government proposed to protect future generations of young people from the lifelong health and economic harms of smoking. There is no argument that smoking is one of the most significant contributors to poor health in the UK and is a driver of health inequalities and disparities. The adverse health risks from smoking put significant pressure on the NHS, with almost 1 hospital admission every minute attributed to smoking and approximately 75,000 GP appointments each month taken up by smoking-related illnesses. Smoking has an economic cost as well to individuals who smoke, their family incomes, and costs the economy £17 billion a year through smoking-related lost earnings, unemployment, early deaths, and costs to the NHS. So, creating a smoke-free generation and tackling youth vaping. On the 4th of October, the Prime Minister, Rishi Sunak, announced his ambition for creating the first smoke-free generation, which was then presented in the King's Speech on the 7th of November 23, stating the anticipated plans by the UK government to consult on new national smoke-free legislations. The legislation proposals include making it an offence for anyone born after the 1st of January to be sold tobacco products. This is a model already operational in New Zealand, as mentioned before, restricting the flavours and descriptors of vaping so that vape flavours are no longer targeted to children to ensure this is done in a way that also continues to support adult smokers. Regulating the point of sale of displays in retail outlets, regulating vape packages and product presentation, considering the restriction of the sale of disposable vapes, another big problem here, which are clearly linked to the increase in vaping in children. Exploring further restrictions for non-nicotine vapes, exploring whether increasing the price of vapes will reduce the number of young people using them, and introducing new powers for local authorities to issue on-the-spot penalty fines. There is a national consultation on smoke-free generation. The consultation is open for submissions and will close on the 6th of December. The consultation has 27 questions that explore the stated proposals with an opportunity to add in recommended novel approaches. Responses are encouraged from individuals, statutory forums, organisation and interest groups. Through the London Tobacco Control Alliance, it has been reported that many have welcomed the launch of the UK-wide government consultation to stop the start of new smokers and address youth vaping. In terms of Hillingdon, smoking disproportionately affects the most disadvantaged in the community and largely contributes to health inequalities. The smoking rate amongst social housing, which is quite an important point here, is one of the highest in England. Around 1 in 3 people in social housing smoke, compared to around 1 in 10 people who smoke in their own home. Each year we estimate smoking costs Hillingdon £192 million. Okay? So, the Hillingdon data shows that the prevalence in OHID is about 8.1%. There are obviously a lot of prevalence in terms of mental health, manual occupations, smoking in pregnancy, but there is also a grant agreement process. The government is investing an additional £70 million per year to support local authority-led stop smoking services. We as a local authority currently receive funding to provide local stop smoking services and support through the public health grant. The new funding is in addition to that and will be provided through a new Section 31 grant on top of the current public health grant allocations. Okay. So, finally, the effect on residents, service users and communities. What will be the effect of the recommendation? This consultation aims to support the implementation of new legislation, has the potential to improve the lives of 19,000 current smokers in Hillingdon and their families, improving their health and income, the societal impact of the cost of poor health associated with smoking on the economy and the NHS. It is recommended that as individuals, organisations and partnership we support the consultation and take action to submit a response. And finally, the report directs the board to the national consultation for local action. Within my role in public health, I have drafted a London Borough of Hillingdon consultation response, including feedback from colleagues in our trading standards team, and the response will be submitted through the online portal once agreed. Thank you. Over to you, Kelly.
Thank you, Sonny. I think unless I'm mistaken, are you going to point it out? Is it the New Zealand? Thank you. I thought I just don't want to point out to a public health person, but I think UK are going it alone. New Zealand have abandoned the idea to stop everyone from smoking. So I think it's just us now. So I got there first, Kelly. Sorry. I know, but just shows I listen occasionally to my portfolio. Thank you, Sonny. As usual, very comprehensive. Does anybody want to make any comments or have any questions, Sonny, on that? Professor Goodman?
So a few things. I think, it's always useful and reassuring to know that there's a significant public health new initiative taking place. And by my calculation, that's going to cost, bring in £292,000 per year to do this. So I'll be interested to see how we can work together to do that. There used to be a plan where GPs would initiate stop smoking programs for our patients, which actually was very successful, but I think funding dried up and that's no longer in place anymore, so it'd be interesting to actually explore that. And on a more pedantic note, there's a table on top of page 55 that gives the 3-year smoking prevalence of 10.1%, which actually makes the population of Hillingdon only 238,000, which seems to be a bit of an underestimate. And I just wondered whether which figure is right. If it's 10%, then our figures should be higher. But if it's 22,614, then our prevalence is much lower, and that's quite important to make sure we know what the baseline data is for that.
Yes, you're absolutely right, Ian. This is data from OHID, and we have sent back a challenge.
That's to see we're ahead of the game there. Anybody else have any comments? I mean, I think, you know, when vaping came in, it was a good idea to help people get off it, but we've created something, a monster, by what's happened with it at the moment. And I think we do need to look at proper enforcement, and I'm sure that's highlighted here. Anybody else have any comments? Otherwise, we're just noting the report. I think, thank you very much, very comprehensive as always. We can move on, I believe, now to agenda item 9, which is but it's the board's business for the forthcoming meeting, so it's for noting. Does anybody have any comments, anything that they want to see on there that's not on there, or want something off that's on there? Tony?
I'll look over at Ian when I say this, just for sort of affirmation as to whether it's a good idea or not. But I was at the external advisory body of the medical school at Brunel the other week, and I just wonder for here whether there should be an update in relation to, because it's making such significant progress, and actually some of its ambitions in relation to how it's going to be sort of reaching out into communities in the borough and ensuring that it's trying to sort of enrich the opportunities of sort of young people to study medicine and so on and so forth. I think it's actually a really good news story, and whether we should, what do you think? Yeah, ask them for an update.
Yeah, I think it's a great idea. I'll give an informal update now if you want, just to give people a sort of a flavour of what's going on. So, yes, it is.
Almost ceased to exist there for a minute.
Wouldn't stand for it, yeah.
Carry on, gentlemen.
So the Brunel Medical School is now in its second year. The first year was very successful. I think everybody passed into the second year, which is unusual. It has it's got a very modern way of teaching, no lectures. It's all done on what's called team-based learning, which actually encourages everybody to take part and problem solve together and work in teams, which actually I think is important for the future generation of doctors, who in the past haven't been the greatest team players in the world. So actually starting from the very beginning of their medical training to be team players is actually a very, very good approach. We're now in the second year, and we've increased the intake to just under 120, about 115 now. But the really good news is that the government's now allowing us next year to take on UK students. So we're going to take 50 UK students and reduce the number of overseas students to do that, which actually is very useful, although the data that we've got is that wherever they come from, 90% tend to stay in the UK to carry on their postgraduate training anyway. And yes, it's looking at various ways. It already has part of its curriculum for the students to go out in the community and work with various agencies, the voluntary sector and the community sector, and that's going to be increased. And what we're hoping to do, though it's very embryonic, is to actually try and work with the public health department to build up our links and do some projects across the community, particularly with the population health management process and inequalities. And I'm happy to bring back a formal report in the next quarter.
Thank you. I think that would be quite useful if we could have, if you wouldn't mind adhering to what you've just said, Professor Goodman, that would be helpful. Another good idea there, Tony.
Every now and again.
Keith?
I wonder whether, just looking at Kelly on this, whether we ought to bring back in March just an update on the health and wellbeing strategy, particularly the baselining component of it, whether that's just ahead of the new financial year. We need then to set that, don't we, into the trajectories for the year that's coming. So if that's possible, then that would be great, I think.
Yeah, but with the commitment of all the partners around the table, that's similar to Vanessa, I think that we could have a sort of more comprehensive and quantifiable way of measuring the impact.
Okay, so you've heard the point Kelly's made. If it will come back, but only with cooperation from everybody else, that'd be great. Are we happy? Can we move on? In which case, if we can, that closes the public part of the meeting. And in a second, we are going to go on to the part of the meeting that is not for publication. So thank you to those of you watching at home. And we will continue without being on camera. Thank you.